So right now, that means applying previous ASCVD prevention and lipid management guidelines to this assessed risk until we have new management guidelines, of course, which will be coming out
Yes.
based on this new CKM framework. So I know that's a little bit confusing, but what are your thoughts on that, Bobby? How do you see this being used, I guess, clinically right now where we are?
Yeah, I think new guidelines will certainly be coming down the road. But until then, we're just going to have to figure out how to act on this new risk assessment in an individualized fashion in the best way possible. And this is me editorializing a bit here. So, but I do think a new approach to CVD prevention is long overdue. For a disease that is still the number one cause of death in America, we have what I think is a very underdeveloped evidence-based approach for prevention. And I think the 30-year risk estimate has the potential to be very helpful, yet difficult at the same time. For example, consider those patients who are estimated to be borderline risk, and that's the 5% to 7.4% 10-year CVD risk. Now, when someone is borderline risk and they have risk factors, it's not really clear cut how aggressive you should be. And that's what we've been used to with the ASCVD risk calculator as well. But cardiovascular disease is one that we know that develops over the course of decades. So the historical focus on 10-year risk seems a bit short-sighted. But this is where we have all the data on interventions such as statins.
Right.
And the scientific statement discussed how the group considered including other predictive markers such as ApoB or BNP, which is the B-type natriuretic peptide, but for various reasons decided against that. And one thing I learned about from this statement was that the AHA had previously released a scientific statement to suggest for patients with a high Lp(a), which is another marker that has been identified as a risk-enhancing factor for ASCVD. You actually could multiply the 10-year ASCVD risk from the PCEs. You can multiply that by a factor of 1.1 for every 50 nanomoles per liter higher of Lp(a) greater than 50. And you could use that to get an adjusted 10-year predicted risk. I'd never seen that before, and I'm going to have to look at that a little more closely. But they did mention that these additional markers could be considered for use in sequential diagnostic testing to reclassify someone's risk. So perhaps identifying someone with subclinical disease that would put them in CKM stage 3.
Right.
This might be the patient you consider getting coronary artery calcium scoring to help you decide how aggressive you really want to be with lipid lowering. Perhaps you obtain a screening BNP level or an echocardiogram in the patient who has a high risk of developing heart failure based on this. We've had all of these different markers out there for a long time, and it's just never been perfectly clear what to do with them in framing your patient's cardiovascular risk. And we're still not there, but I think we're moving in that direction. There actually are medications that are coming out that likely are going to specifically lower Lp(a), which we've never had medications that do that before. So I anticipate that in the future, if doing that actually is shown to improve cardiovascular outcomes, then that may be something we're treating in the near future. But we've all understood for a long time that patients that have this chronic disease trifecta of metabolic disease, cardiovascular disease, and kidney disease, and now it's actually being called something, called CKM syndrome. And they've developed this over time, and we knew that they were all connected. But now it seems that we actually have a useful tool that incorporates a lot of these considerations, and we might be able to have better risk prevention discussions with our patients in the future.